Welcome, everyone. This is Bob Martindale. I'm out in Portland, Oregon right now, and I'm glad you're joining us. I'll be moderating today's session with the other faculty members, but I'll do most of the moderating. Today we're doing Hot Topics, as we've done for several years now. This is Hot Topics 2020, which is really looking at contemporary issues in general nutrition support. So, as introduction, the Nestle Nutrition Institute Clinical Nutrition Fellowship has been ongoing now for upwards of 10 years. Been as a faculty, myself, Steve McClave, Laszlo Karai, Keith Miller, and Ryan Hurd serve as the faculty. And we've now trained 62 physicians have completed this program. We select 6 fellows per year and participate in a 4-week intensive didactic total immersion training, which 2 weeks is spent in Louisville and 2 weeks is spent in Portland, Oregon. The faculty, as I just mentioned, all participate in all the sections. Ryan Hurd travels from Mayo back and forth and gets involved in both groups. This year's fellows, this program started with trying to get fellows, GI fellows, surgical critical care fellows, etc. But it ends up that we're now getting mostly applicants are young faculty members. As you'll notice this year, the 6 faculty members are in fact Vikram Krishan from Minnesota, Indasha Omar from Louisville, Kentucky, Caitlin Hamburger Green from MUSC and Medical University of South Carolina, Rebecca Bush from University of Wisconsin, Sadiq Qurashi from Tufts University, and David Williams, who won't be joining us today because of COVID-19. He's been pretty busy at Duke. And David Williams, I mentioned, won't be with us today. Each fellow will be introduced prior to his or her presentation, and we'll go from there. So now the objectives of today's discussion, each one will have his own objectives. Again, this is a wide range of topics, and each one will have his own objectives on there, but basically discuss the aspects of the relationship of the microbiome, identify diagnosing malnutrition, intensive care unit, and describe the pre-op nutrition optimization programs. So I'll turn it over to Vikram at this point. So Vikram, do you want to go ahead and start yours?
Sure, Bob. Good morning, everyone. I'm just going to open up my slide over here. My name is Vikram Christian. I'm an assistant professor at the Department of Pediatrics, a division of pediatric gastroenterology at the University of Minnesota in Minneapolis. I'm going to be talking about food insecurity, malnutrition, and the microbiome. I have no conflicts of interest to disclose. My objectives of this presentation are to define and discuss the prevalence of food insecurity and to demonstrate a link between malnutrition and the microbiome. Simply defined, food insecurity is the disruption of food intake or eating pattern because of lack of money and other resources. USDA defines this as a household-level economic and social condition of limited or uncertain access to adequate food. The USDA defines food security as the access by all people at all times to enough food for an active, healthy lifestyle. In 2006, the USDA introduced new language to describe ranges of severity of food insecurity and created this food security pyramid. High food security households, right at the top, are those with no problems or anxiety about consistent access to adequate food. Very low food security households, right at the bottom here, are those where the eating patterns are disrupted and food intake reduced because the household lacked money or resources. These are some of the characteristics of food insecure households when compared to food secure households. This data is again from the USDA. Of note, more than 40% of very low food insecure households lost weight. Food insecurity crosses state lines. 14.6% of all US households are thought to be food insecure. The states of Mississippi, Texas, and Arkansas have the highest rates of food insecurity, while North Dakota, Massachusetts, and Virginia have the lowest rates of food insecurity. Nationally, it is estimated that 49.1 million individuals live in food insecure households. That is 16% of the population of the United States. Unfortunately, food insecurity is an international issue. This map shows the prevalence of food insecurity and severe food insecurity worldwide. The prevalence of food insecurity in North America is 12%, and severe food insecurity is 3% according to this source. Here you will also notice that the prevalence of food insecurity is much higher in South American, African, and South Asian countries. The worldwide prevalence of food insecurity is 26%, and severe food insecurity is 11%. Although intuitively it would seem that food insecurity and malnutrition are closely connected, a systematic review from the Food and Agriculture Organization of the United Nations, or FAO, does show mixed association. 19 studies looking at food insecurity and childhood stunting, a well-studied indicator of childhood malnutrition, showed positive association. 3 showed mixed association, and 7 showed no association. 3 studies looking at food insecurity and childhood wasting showed positive association. 1 showed mixed association, and 11 showed no association. In studies linking food insecurity and low birth weight babies, all 3 studies showed a positive association. Looking at food insecurity and anemia in women, the results were mixed. A complex interplay between poverty, food insecurity, poor public health, infectious diseases, chronic diseases, poor education, climate change, and several other factors are thought to lead to malnutrition. Recently, the gut microbiome has also been implicated to play a role in the development of malnutrition, and we will talk a little bit more about that in the remainder of my time. This paper, published in Science in 2013, illustrated this relationship well. The authors followed 378 Malawian twin pairs for 36 months. As you will likely know, Malawi is a country in sub-Saharan Africa that is poverty-stricken and has a high prevalence of HIV/AIDS. The authors focused in on twin pairs where the growth was discordant. That is, where one member of the pair had normal growth and nutrition, and the other member of the twin pair had kwashiorkor. Both twins were fed a ready-to-use therapeutic food which comprised of peanut paste, sugar, vegetable oil, and milk, fortified with vitamins and minerals. This ready-to-use therapeutic food is widely considered to be the international standard treatment for severe acute malnutrition. The authors found that there was a transient maturation of metabolic function in the kwashiorkor microbiomes, and this maturation regressed when the therapeutic food was discontinued. In order to arrive at this conclusion, the authors studied the normal microbiome in healthy Malawian twin pairs over time and were able to define the normal microbial maturation process in this population. On the right side of the screen, you will see the maturity of the metabolic function of the microbiome in healthy twin pairs on top and the discordant twin pairs below after being fed the ready-to-use therapeutic food. The kwashiorkor twins seen here at the bottom right showed transient maturation, but this was short-lived. The authors went on to transplant the previously frozen fecal communities from the discordant twins into norobiotic mice. They showed that exposure of the mice with the kwashiorkor microbiome to a Malawian diet led to weight loss, and this was associated with disturbances in amino acid, carbohydrate, and intermediary metabolism. Here you can see the decrease in weight of the mice with the kwashiorkor microbiome in blue on the regular Malawian diet compared to the twins with the healthy growth in red. This decrease in weight reversed when the diet was changed from the Malawian diet to the ready-to-use therapeutic food, or the RUTF. This study did receive a lot of positive press and praise, as it did seem to reveal a previously undiscovered link between gut bacteria and malnutrition. This study also led to other studies like this one looking at gut viromes and malnutrition, another study looking at the microbiome differences between kwashiorkor and marasmus, and an animal study looking at probiotics and protein energy malnutrition. It also led to this study that was conducted among Bangladeshi children. A machine learning-based approach was applied to 16S ribosomal RNA data sets from monthly fecal samples from children who exhibited healthy normal growth. This data was incorporated into a model that computed a relative microbiota maturity index and even came up with a microbiota for age Z-score. Analyzing children with severe and moderate acute malnutrition, the authors found that severe malnutrition was associated with relative microbiota immaturity. Children with severe acute malnutrition were further enrolled into a randomized trial of 2 food interventions, a ready-to-use therapeutic food, or RUTF, versus something called as khichdi halwa, which was a local food option. The microbial maturity of children in each arm of the trial are compared here below, before the trial, at the end of the intervention, less than 3 months after intervention, and greater than 3 months after intervention. The authors found that although growth improved, the microbiota immaturity was only partially improved with both nutritional interventions. The authors concluded that either prolonged intervention with therapeutic foods or the addition of gut microbes may be needed to achieve enduring repair of the microbial immaturity and thereby improve clinical outcomes. This concept of repairing the microbiome brings us to this study that was published in Science in 2019 by the same group. The top half of the slide refers to the work that was illustrated on the previous slides. That is, the authors defined normal gut microbiota in healthy children in Bangladesh. The authors went on to analyze the metabolomic and proteomic data from serially collected plasma samples combined with metagenomic analysis of serially collected fecal samples of children treated for severe acute malnutrition as they transitioned to a state of moderate acute malnutrition. Sorry, I think somebody went through the slides. I'm just going to go back to the slide. Give me just a minute. Next, the gnotobiotic mice were colonized with bacteria from these children, and food were offered to see what would be able to promote the weaning phase bacterial taxa. The authors referred to a set of bacterial taxa as weaning phase taxa. These bacterial taxa were targeted as they were prominent in healthy children but lacking in children with severe malnutrition. The authors formulated something that they called as microbiome-directed complementary foods, or MDCFs. These were made using culturally acceptable, affordable, and readily available ingredients. The authors selected ingredients that were more likely to promote this weaning bacterial taxa. The authors then proceeded with a randomized double-blind clinical trial in Dhaka, Bangladesh, in which 63 children were enrolled. The authors compared an RUSF, or a rice and lentil-based ready-to-use supplemental food, to 3 of their MDCF prototypes. Now, MDCF 1 and 2 contained chickpea flour, soy flour, peanut flour, and banana in different concentrations. MDCF 3 contained chickpea flour and soy flour. Each formulation was equivalent in calories and protein content. The children were fed 2 servings a day on top of their regular diet. The authors were able to identify a lead MDCF, that is MDCF2, shown here on the left, that increased levels of biomarkers and mediators of growth, bone formation, neurodevelopment, and immune function towards a state resembling healthy children. This is seen on the left side of the slide here. Now, this study has also received much attention and has set the stage for other studies looking at the role of the microbiome and microbiome-directed foods in the management of malnutrition in the developing world. It may be too early to determine the implications and future applications of these studies. However, important questions to ask would be, are the effects sustained? Are the effects or are the results generalizable in other populations? What does an MDCF look like in another population? And most importantly, does this microbial immaturity exist in other malnourished populations? The authors are currently involved in a longer duration study to determine if these effects are sustained. As I conclude this presentation, I hope that I have been able to introduce the concept of food insecurity to some who may not have been familiar with it. Food insecurity is truly a significant national and international problem. The link between food insecurity and malnutrition is unclear. Some studies do show positive association, but some also show mixed and no association. Malnutrition is a complex phenomenon and may relate to immaturity of the host microbiome. And finally, it is too early to say if microbiome-directed foods will help with impoverished and malnourished populations. Thank you all for your attention. Thank you, Nestle Nutrition Institute, for this opportunity, and thank you to all the faculty for your mentorship over the past year.
Vikram, that was fantastic. I hadn't seen some of those studies. That most recent 2019 study really brings up some very interesting things. So what is your thought for the future? Where do you think we're going?
So, Bob, the study was 63 children, and they tried 4 different interventions. They tried the ready-to-use lentil food and 3 different microbiome-directed complementary foods, or MDCFs. So, which means that the number was probably small in each arm, and it was a short-term trial. And so, I think it might be a bit too early to say exactly what the effects are. Also, the study was done in a very specific, small population in Bangladesh. So, I'm not sure how generalizable it will be. But the authors are working on a longer study, a longer duration study. So I think we might know answers in the coming year or so.
Fantastic. I don't see any questions in the question box. Any other faculty have a question?
Yeah, Bob, are we holding questions to the end, or we're going to do questions?
Yeah, we can probably go. You're right. Yeah, we'll just round that one up. Okay, let's hold to the end, and we'll go to the next speaker. Yep. Then we'll have a time for roundtable.
Okay, because I've got questions for Vikram, but we'll hold till the end.
Okay, so next will be Rebecca Bush, the role of cross-sectional imaging in diagnosing malnutrition in the critically ill patients. As most of you know, this is a very hot topic, and when should we use cross-sectional imaging, and how should we teach it to a broad range of healthcare providers, from nurses, dietitians, anybody else who might be involved in the treatment of this patient. So Rebecca, you can go ahead.
Hi, good morning, and thank you for the opportunity to present today. All right. The incidence of malnutrition has been reported to range from 40 to 70% in critically ill patients. Identifying patients at risk for developing malnutrition and associated sarcopenia is paramount to recovery from critical illness and providing timely and optimal nutrition intervention. Today, we will review the current methods for diagnosing malnutrition in the critically ill and discuss the potential for cross-sectional imaging in helping to make this diagnosis. We'll start by looking at current methods. Malnutrition comes in many shapes and sizes, making it difficult to diagnose, particularly in the ICU. Current methods for diagnosing malnutrition in the critically ill remain somewhat obscure and cumbersome. Unfortunately, many commonly used screening tools were not designed for critically ill patients. In an effort to increase objectivity, the Academy of Nutrition and Dietetics, ASPEN and ESPENS, put out a consensus statement to define malnutrition in 2012. They advocated for using etiology of disease to evaluate 6 clinical characteristics. Recognizing the components of nutritional risk to be a combination of nutritional risk and disease severity, they divided disease etiology into 3 broad categories: starvation related without inflammation, chronic disease related, and acute disease related. They took these etiologies, the starvation related without inflammation, chronic disease related, and acute disease related, then evaluated 6 clinical characteristics with regard to each etiology and used this as a basis for diagnosing malnutrition. 2 criteria were required for diagnosis. While this does provide a more objective working framework, it's somewhat cumbersome and again was not developed in critically ill patients. In an effort to evaluate the critically ill, Highland et al. Developed the Nutrix score, which is a nutrition risk assessment tool that was developed in the critically ill to help identify patients who would benefit most from nutrition therapy. Increasing Nutrix scores are associated with increased risk for mortality, as seen on this chart, with Nutrix scores on the x-axis and mortality on the y-axis. It is worth mentioning that initial Nutrix score included IL-6, which is not readily available, so a modified Nutrix score excluding IL-6 was revalidated with similar findings. In either case, however, the Nutrix score and modified Nutrix score do not provide a diagnosis of malnutrition and have limited content validity in terms of classical nutrition variables such as BMI, recent weight loss, and recent food intake, making it more difficult to interpret. Outside of the Nutrix score, current tools for nutrition assessment in the critically ill rely on weight, BMI, or pre-hospital weight change. These anthropomorphic measures may not capture body composition, may be skewed by fluid status, or may be difficult to obtain through history. For example, if you take a 5'11", 220-pound bodybuilder and compare him with a 5'11", 220-pound sedentary man, there will be inherent differences in body composition and associated outcomes. So while the numbers may look the same, the patients can look very different. Additionally, lab markers should not be used to evaluate nutrition status in the acute setting, as they are affected by the acute phase response. So we are left with the question, is there a better way to determine nutritional status in the critically ill and risk stratify our patients? An ideal tool would be a single, widely available marker that is cheap and reproducible, requires limited patient participation, is unaffected by edema or inflammation, differentiates between different body compositions, and most importantly, reflects nutritional status. And while it is not cheap, CT scans may represent a useful tool in diagnosing malnutrition in the critically ill. So let's focus on why. As alluded to earlier, body composition can have a large impact on patient outcomes. And in particular, lean body mass is a key predictor of outcomes in critically ill patients. Sarcopenic patients, or patients with decreased muscle mass, have higher mortality, more ventilator days, longer ICU stays, and longer hospital stays than their non-sarcopenic counterparts. Additionally, as mentioned, current anthropomorphic measures such as weight and BMI do a poor job of identifying sarcopenia, particularly in the obese. CT scans allow us to perform body composition analysis. So what do I mean? This picture shows CT scans of two 58-year-old male diabetic patients, each with a previous myocardial infarction and COPD, who are being evaluated in clinic for elective surgery. While on paper they appear medically similar, the CT scans taken at the same level show body composition differences between the two patients that may not be otherwise recognized. On the patient on the left, you see smaller and less clearly defined psoas muscle groups compared to the robust and clearly defined muscle groups of the patient on the right. This is how we evaluate sarcopenia using CT scans. Here's another example. These are slices from CT scans taken at the third lumbar vertebra of 3 different patients who all have a diagnosis of esophageal cancer but very different BMIs. The one on the left is underweight with a BMI of 17.5, and the one in the middle is overweight with a BMI of 25, and the one on the right has class 2 obesity with a BMI of 38. Body composition is outlined by color here, with red indicating skeletal muscle, yellow indicating visceral fat, blue representing subcutaneous fat, and green representing intramuscular fat. What you see is that while you recognize the patient on the left is frankly cachectic based on BMI and little intra-abdominal fat and severe muscle depletion, you would clinically miss evidence of severe muscle wasting that is present in our overweight and obese patient. In fact, both the overweight and the obese patient have similar muscle mass as the frankly cachectic patient on the left. This image demonstrates the concept of otherwise hidden sarcopenia in these patients. Here's another example looking only at skeletal mass, which is highlighted in red on these CT scans at the third lumbar vertebra. On the top row, we see female patients with identical skeletal muscle index in centimeters squared per meter squared, but having different BMIs. Here, skeletal muscle index is defined as the cross-sectional areas in centimeters square of the sum of all the skeletal muscles at the lumbar 3 level, normalized for height in meters squared, or basically everything that is highlighted in red in these pictures divided by the patient's height. The patient on the left has a BMI of 40.2, while the patient on the far right has a BMI of 15.3. You can see how without the CT scan, you might not recognize the low muscle mass in the obese patient. The bottom row highlights variation in skeletal muscle index for female patients with identical BMIs and different skeletal muscle indices. You can see that the patient on the bottom left has decreased skeletal muscle mass compared to the patient on the right. There's an increasing body of literature demonstrating worse outcomes in sarcopenic patients in the critically ill, significantly increased hospital mortality in critically ill sarcopenic patients compared to non-sarcopenic patients. Twice the mortality in elderly critically ill trauma patients who were sarcopenic compared to non-sarcopenic. Sarcopenic patients also had decreased ventilator-free days, decreased ICU-free days, and less probability of being discharged home. And further evidence supports that predictive equations to estimate lean body mass are not accurate in the critically ill, as lean body mass was overestimated by 13 to 18% in critically ill patients by the predictive equations when compared to CT. This is not surprising given that the equations were developed from healthy and chronically ill patients. Additionally, sarcopenia assessed by abdominal CT demonstrated low correlation with BMI and was a risk factor for lower 30-day survival, higher hospital mortality, and higher complications in critically ill patients. Sarcopenia is also highly prevalent among patients with respiratory failure requiring mechanical ventilation and was not readily detected in patients classified as normally nourished using the subjective global assessment. Among patients with CT-identified cancer cachexia, the malnutrition universal screening tool and the malnutrition screening tool categorized 27% and 35% of them as low nutritional risk, respectively. Additionally, several diseases have been shown to have outcomes correlated with body composition, including pancreatic cancer, colorectal cancer, esophageal cancer, hepatocellular cancer, lymphoma, the critically ill, and general surgical and medical care. CT scans are not the perfect tool for diagnosing malnutrition. In addition to the cost and radiation dose associated with CT scans, obtaining CT scans requires patient transport out of the ICU, which can pose logistical challenges. Additionally, resolution in different protocols may introduce variables in results. Further, patient position can interfere with the measures of cross-sectional area and alter results. Alternatives to CT scans for measurement of body composition do exist. Ultrasound would be the cheapest and easiest alternative. However, it is frequently user-dependent with significant intra- and inter-rater variability. Bioimpedance is unfortunately not ideal for critically ill patients, as edema associated with critical illness impacts the tissue resistance and skews measures. DEXA and MRI have a lot of the similar issues as CT scans. Use of imaging to help diagnose malnutrition, however, raises further questions. Questions including, how do we measure if our interventions like rehabilitation, nutrition therapy, and physical therapy are working? While some patients, particularly the critically ill and cancer patients, do receive serial CT scans, this is much less common. Further, the Joint Commission guidelines also mandate periodic rescreening at regular intervals to capture patients who become malnourished in the setting of prolonged hospitalization. So admission CT scans would not capture these patients. I would argue that many patients undergoing CT imaging as part of their normal medical care or undergo imaging as part of the normal medical care, and these images are an untapped resource that we are not taking full advantage of. I think that available imaging may be a more feasible way to effectively screen and assess critically ill patients for malnutrition. We could also evaluate outcome measures of intervention in patients classically receiving serial scans, such as trauma, cancer, and some surgical patients using these techniques. Ultimately, I think local protocols for measuring sarcopenia should be adapted, and that we should at least keep sarcopenia in mind and review images specifically for sarcopenia when taking care of our patients. I'd like to thank the Nestle Nutrition Institutes for the opportunity to present this information.
Great. Rebecca, that was very good. We'll have some good questions for you at the end, because I think this is obviously a growing technique, but we can maybe even make it better, and I'm sure you'll have some explanation for us. Thank you. So we'll head on to the next one now. The next one's going to be, let me see if I can pull it up here. It's going to be Indisha Omar from University of Louisville there with McClave. He's going to talk about the microbiome and obesity. Indisha, go ahead.
Good morning or good afternoon, everyone. My name is Indisha Omar from University of Louisville. I'm going to talk about microbiome and obesity. As we all know, obesity has been associated with a plethora of metabolic disturbance, including coronary disease, liver disease, and recently several forms of cancer. Interest has grown recently about if microbiota, which we live with over 4 trillion, could have a role in obesity and other metabolic disorders. So my goal is to see if there is any potential causality, as well as if they could serve as a target for intervention. Next slide.
Can you, oops.
So the magnitude of the problem, obesity, is a global pandemic, especially in US. Over the last 30 years, it has grown exponentially. In 1990, less than 50% of, there's no prevalence over 15% in any state. However, just 30 years later, there is no state with a prevalence under 20%. So the prevalence has grown in just 20 years, over 40% from 30 to 42. For decades, obesity has been viewed to be caused by simple imbalance between intake and expenditure with the KICO mentality. If the pathogenesis of obesity had been that simple, Hippocrates' prescription, eat only once a day, take no baths, and sleep on a hard bed, and walk naked as long as possible would have been successful. But it's more complex than that. We know now that energy metabolism in human body is complex, and many factors may influence the risk of becoming overweight or obese. Recently, interest has grown exponentially if microbiome could play a role. However, evidence mainly originates from studies in mouse models. Data showing causality in humans are scarce. The adage, we are what we eat, could be changed to we are what our gut microbiome transforms into. Antibiotics are widely used in humans as well as in livestock. There is a parallel that the microbiome antibiotic use in obesity in humans. States with the highest antibiotic prescription has correlated with higher obesity prevalence. So this raises the notion that antibiotics might alter gut microbiota, leading to obesity. This interesting observation has been investigated in animal models. In this particular study, mice with normal microbiota, if transferred to germ-free mice, no change in body composition. Also, there is no change if antibiotics are given prior to weaning. However, if the mother receives antibiotics during pregnancy as well as throughout weaning, the pups tend to gain more weight. And this obesity phenotype is transferable if fecal material is transferred to germ-free mice. So this has shown more interest, and many studies have been conducted to prove that association. In this particular study, if microbiota is transferred from normal mice to germ-free mice, no change in body composition. However, transfer from obese mice to germ-free mice, obesity phenotype is conferred. How about in adulthood? Disruption of normal gut microbiota can occur after short course of antibiotics, but in most people, this change is short-lived. However, it could persist over 2 years with increased risk of development of obesity. Antibiotic lower diversity, showing increased abundance of firmicutes coupled with decrease in bacteroids. But this ratio of firmicutes versus bacteroids have been challenged by other studies, showing that the lower firmicutes, especially particularly with reproducers, could lead to obesity. The most important thing is decreasing diversity leading to peripheral resistance. Above all, instead of the microbiome themselves, the metabolites play a great role. How about role of microbiota in obesity? Gut microbiota can lead to metabolic and weight change in the host. In germ-free mice, they weigh 42% less, despite eating 29 less chow. If microbiota from normal mice is transferred to germ-free mice, they tend to gain 50% weight, despite eating less. This was further investigated that if any high-fat diet could result in different body composition. In germ-free mice, despite eating the same amount of high-fat diet, germ-free mice showed no change in body composition. However, if in normal microbiome, they tend to gain weight, which amplifies the metabolic effect of high-fat diet. How microbiota dysbiosis is, as I alluded earlier, it's a derangement in both composition and function. Gut microbiota can extract as high as 200 kilocalories per day in normal adults, But this extraction can be amplified in state of dysbiosis. Short-chain fatty acids play a great role in modulating satiety as well as generating more energy. Also, they might have effect on bile acid metabolism with reduction in obesity protective bacteria. Circadian rhythm is also involved in metabolism, especially in obesity. If we have intact host circadian rhythm in feeding habits, microbial donor rhythmicity will be observed high and low rhythmicity with normal energy metabolism and cell repair and function, so resulting in metabolic homeostasis. However, if there is impaired circadian clock and feeding habits like in jet lag or shift work, results in loss of diurnal rhythmicity of microbiome, both functionally as well as compositionally, resulting in dysbiosis, leading to obesity and glucose intolerance. There is an elegant study that showed time-restricted feeding could protect from obesity or can be used treatment. In this study, mouse are led to eat whenever they want throughout 24 hours. But in time-restricted feeding, where they are eaten when they are active, which translates to humans during the daytime, in the part in mice at night, there will be high amplitude in microbial oscillation, both functionally and structurally, creating favorable metabolic outcomes, decreasing adiposity, less glucose intolerance, decreased leptin, and so on. This is a summary how microbiome could affect several obesity through several pathways. They might generate more energy by breaking down indigestible polysaccharides, or they might affect satiety by producing less bitrate, the shift from bitrate producing to non-bitrate producing microbiota, or they might alter bile acid. As we know, bile acids have several functions, including like fat emulsification, as well as they are hormones through FXR receptors, which help in glucose homeostasis. Also, they can create metabolic endotoxemia, leading to insulin resistance. Can diet play a role in microbiome? Microbiome show a great deal of plasticity. They compositionally as well as genetically to environmental stimuli. Shifting gut microbial composition can occur as early as 3 days of intervention. Fiber induce both compositional as well as functional change in gut microbiota. The response to any intervention, including fiber, is better at the baseline if the microbiome is less diverse. As we know, emulsifiers in Western diets disrupt the barrier function, less microbial diversity, leading to obesity phenotype. This can be prevented by fiber supplementation. How about prebiotics? Can prebiotics help or modify our gut microbiota? The answer is yes. Oligofructose enriched altered gut microbiota could improve weight and adiposity, improve systemic inflammation. Fiber-rich diet could decrease adiposity. Especially this is observed in Akkermansia, where it accounts about 5% of the total microbiome population. When probiotic oligofructose is given to obese mice, there's increase in abundance of Akkermansia about 100-fold, with a resultant decrease in metabolic profile like fat as well as insulin sensitivity. How about probiotics? Can they help? Conflicting results, species-specific, some lactobacillus species induce weight loss, while others no change, also might increase weight. However, there is a consistent finding that Akkermansia could have beneficial effects in improving weight loss and improved fat to lean mass ratio. In humans, randomized controlled trial in overweight and obese individuals with Akkermansia showed improved metabolic profile. How about bariatric surgery? Bariatric surgery alters gut microbiota composition. This occurs way before weight loss, improved in diversity. Fecal microbiota transfer from patients with bariatric surgery improved, induced weight loss in recipients. How FMT has been investigated in animal models, has shown that the transfer to obese germ-free mice showed confers obesity from lean individuals remained lean. There are few studies in human, 2 Dutch studies and 2 US studies. The 2 Dutch studies did not show improving BMI, however, showed improved in insulin sensitivity at week 6. But the key finding here is a response is seen in patients who have less diversity at baseline. 2 US studies used oral capsules of which are safe and tolerable, but no effect is seen. In summary, the gut microbiota is linked to obesity. However, the magnitude of association is not clearly clear. It is not entirely clear. We know that obesity pandemic parallels increased antibiotic use and resistance. Gut microbiota disorders can alter body habitats, energy metabolism. Especially short-chain fatty acids play a great role, with being protective, serving as substrate, immune cell regulators, and gut hormone modulation. How about other short-chain fats like acetate and bitrate could promote obesity by providing more energy? In general, obesity involves complex interplay between multiple factors like host genetics, environment, microbiome, and metabolomics, and gut permeability. Thank you, everyone, Nestle, and Dr. McLeod, for your help. Thank you.
Omar, that was very, very interesting. We got lots of questions. We'll have them for you at the end there, because I think this is an area which sounds easy, just give the right thing, but then you see it doesn't have much effect in many cases, so we'll have lots of questions. Okay. So now we'll go on to Sadiq Qureshi, who's going to give us a discussion of the opioid epidemic and how that fights, do we have the guts to fight it? And I think it's going to obviously bring in the issues related to nutrition for us. Sadiq, go ahead.
Thank you, Dr. Martindale. I want to thank the Nestle Nutrition Institute for sponsoring the Fellows Program and giving me the opportunity to present, and certainly to all the faculty in the program for their mentorship, and to my co-fellows for all the back and forth and the learning. Very much appreciate it. And thank you to all, I guess, 400 people that have logged on to attend. So as Dr. Martindale alluded to, I'm going to be talking about sort of the microbiome and how that may be related to the current opioid epidemic. So the first thing to get out of the way is really the issue of nomenclature. The people go back and forth talking about opioids and opiates, and sometimes there's a little confusion about exactly what we're talking about. So the cartoon on the left there really helps us understand that opiates are natural substances or direct derivatives of natural substances, and they fall into the larger category of opioids. So opioids include the opiates and all other synthetic opioids, which are the ones that we typically use clinically, in terms of fentanyl and oxycodone. However, morphine, which is an opiate, is still used quite a bit in clinical practice. Now, when we talk about opioids, we all understand that we're talking about their effects on the opioid receptors, and there's 3 major receptors. There are actually 2 subtypes of the mu receptor, but that's beyond the scope of this talk. The beneficial effects are predominantly mediated through the mu receptors, but all the other receptors are involved in various side effects that are typically attributed to opioids. And as you can see, I've highlighted the one that's of most important to us, which is the slow gut transit time. So One of the things that has been described as being central to this opioid epidemic is this initiative of pain as the fifth vital sign. It clearly started off with noble beginnings in the 1980s when it was recognized that patients with HIV and full-blown AIDS, that their pain was being significantly undertreated. And from that, a series of different initiatives took on until about the mid-1990s, when the American Pain Society really came out and started proposing this idea of pain as the fifth vital sign. It wasn't until the late 1990s when the manufacturers of OxyContin and various other opioids started to push a large PR campaign, essentially saying that if opioids were used for the treatment of true pain, that they were non-addicting. This statement really wasn't based off of any science, and it was more of a PR campaign than anything. But it really caught on, and people started to really think that that was the issue, to the point that in early 2000, the Joint Commission actually started putting pain management as one of their criteria for accreditation of hospitals. And even Medicare and several other reimbursing bodies started making pain a major issue. And so as a result, of what really started off with noble beginnings, this whole initiative played a large part in what we see today as the opioid epidemic. So you can see on this cartoon here today, about 130 people die every single day from opioid overdoses. And if you look to the right, you can see that from the time when this whole pain as a fifth vital sign took off, there's been a steady increase in the use of natural and some of the lower, tiered synthetic opioids. But now, since the attention has fallen on trying to reduce opioid prescription by physicians and healthcare providers in hospitals, there's been a dramatic uptick in heroin and other more powerful synthetic opioids because of people being tolerant. That's concerning because these other opioids, like heroin and more powerful synthetic opioids, the overdose potential is much greater, and that's why we're seeing more fatalities associated with opioid overdoses. So, some of our speakers earlier have talked about this and have alluded to this, that, since the 1970s, there's been this interest in what's called the gut-brain axis, that there's crosstalk, neurohumoral, crosstalk between the gut and the brain, and it modulates various propensity to disease states. And as you can see on the diagram on the left, issues like weight gain, bowel movements, nutrient delivery, all of these issues are, intimately involved in this in this gut-brain axis. But turns out that pain also is intimately involved. And as you can see in that middle cartoon there, that, there are descending pathways. So there's the hormonal pathway, there's the neural pathway, and the neurotransmitter pathway. And then those modulate the gut and then feed back to the brain and modulate activity in the brain. And certainly when you look at chronic pain states, the cartoon on the right basically is a representation of fibromyalgia, and that's the classic pain syndrome that's often studied. You can see that the microbiome is very different in women who have established fibromyalgia versus controls who don't have fibromyalgia. And if we take a look down more at the sort of the pathways that are maybe associated with it, you can see on the left over there that there are multiple neurotransmitters that are involved here. There's the 5-HT, GABA, tryptophan, and histamine, various inflammatory mediators, and you can see that there is direct neural stimulation into these, in addition to just the upregulation or downregulation of these molecules. What's also important here, it is worthwhile noting, is the epithelium, and under it is where the gut microbiome lives, and the short-chain fatty acids. As we know, short-chain fatty acids are very important in maintaining epithelial integrity, which in turn is important for maintaining gut microbiota. So all of these are sort of intertwined. And as you can see on the diagram on the right over there, that there are afferent and efferent pathways that can cause dramatic changes in regulation. So, for example, this one shows changes in tryptophan and 5-HT, that when those are stimulated, there's an increased reabsorption and release of tryptophan into the luminal pathways, which then causes an upregulation in potentially pathogenic bacteria such as Clostridia. So the changes in these molecules can have a dramatic effect on the microbiome, and these are for pain states. Well, so this is pain, and to treat most types of pain, we typically use opioids. And when you think about the targets for opioids, if you look on the left, that's the one that we're typically used to in terms of the CNS, right? So there's the peripheral, the spinal cord level, and then the cortical level of where the opioids act. And it's been known for a very long time with repeat doses, there's tolerance to opioids. And when if you look on the right, when you look at opioid receptor density within the GI tract, you can see that it predominantly exists within the muscles. And so it makes sense that with, increased exposure to opioids, there's a, slowdown of peristalsis, and gut motility suffers as a result of that. Well, these are animal studies that I'm going to be predominantly talking about because there aren't really a lot of good human studies. But in this study, very interestingly, what the authors did, and and I'll try to go through this. It's a little complicated. What this is showing is the clustering of the microbiome, and what we see is there's one group of mice that got exposed to injections of morphine, another group that was exposed to morphine and given oral naloxone, a group that was just given oral naloxone, and then a group that was just given placebo. And what you can see, A, on the left-hand side is baseline, B is day 1 after exposure to opioid or placebo, C is day 2, and D is day 3. And then on the right-hand side, the one that you see in the middle, that cartoon is days 4, 5, and 6. And as you can see, with repeat exposure to opioids in just the morphine group, you see that the microbiome is diverging. It's completely different from all the other groups. There's relative clustering of all the other groups, but that microbiome in the morphine-exposed group is completely off, and it's in a different place. And what really important with this study is that, the reason why they gave the oral naloxone is because it antagonizes the effects of opioids in the gut. So it doesn't allow for slowing of the gut when these mice are exposed to injections of morphine. And you can see that when they receive the naloxone, the microbiome in those animals is very similar to the other animals and is very distinct from the group that just got morphine. So this is very convincing data or compelling data that suggests that gut motility is incredibly important in at least the initial stages of the dysbiosis that we see with opioid administration. The same investigators then basically looked at repeat morphine doses and looked at what that does to the alpha and beta diversity. So alpha diversity is, for those of you that are unfamiliar with this, is the richness in the types of, I don't know why this is moving, but sorry about that. In the alpha diversity is the sort of the richness of the different types of species that are in samples, and the beta diversity is how different samples are from each other in different animals. And so when you compare animals that receive morphine versus those that received placebo, what we see is that the alpha diversity decreases significantly in those that were given morphine, but the beta diversity between these samples increases so that they're very, very distinct profiles of the microbiome. And if you look on the right-hand side, you see the heat map of the 16S ribosomal mRNA, and you can see upregulation of multiple different types of potentially pathogenic bacteria in the animals that received morphine. And they took this one step further. What they identified in these animals was that E. faecalis was highly associated with pathogenicity. And so what they did is they took animals and they had various, and if you look on the left-hand side, they had various controls, but the important lines there are really the purple and the green line. So the green line is animals that received morphine and just PBS. And then the purple line is they received morphine and eficalis as an injection. And what they were able to show is that, and the graph is basically showing analgesic response. So as you can see with repeated doses with the morphine and PBS, there's decreased analgesic response as you get more and more opioid exposure. But if you give morphine with eficalis, there's further blunting. So your morphine is less effective. And so what this suggests is co-administration of the eficalis with the morphine really further attenuates the analgesic effect and increases tolerance to opioids. In a separate lab, basically did a couple of very interesting experiments here. And so what they did was they initially started, if you look on the left-hand side, the SPF, which is the specific pathogen-free mice, and then they sterilized them with antibiotics and create the germ-free mice. And then what they did is they took fecal transplants from donor animals that had either grown up with injections of saline or injections of morphine. And then they took these two different animals, the saline microbiome and the morphine microbiome, and then exposed them to either saline or morphine. And you can see, so first of all, if you look on the lines on G and H, so G is a pain response to tail flick, and then hot plate is obviously heat as a noxious stimulus. And what you can see is those blue little triangles. So that is the saline microbiome being exposed to morphine, which is what you expect, right? Repeated doses of morphine, you're going to have decreased analgesic effect as tolerance builds up. But what's very interesting here is that the next, and then that is actually different from if you just took a specific pathogen-free and exposed it to morphine, which you saw that tolerance builds up a little bit faster in that population. But what's most notable is that the animals that were germ-free and then received the morphine microbiome, when they were further exposed to morphine, had the most dramatic blunting of analgesic effect and had the fastest tolerance developing in them. The same investigators basically looked at sort of the relative abundance of different types of bacteria, fecal samples and gut samples. And so on the top over there, what we can see is that there's relative abundance of lactobacillus and bifidobacteriaceae. And they looked at three different types of mice. So they looked at the wild type, which is just the normal mice, and then they looked at TLR2 and TLR4 knockout mice. And I'll explain this a little bit further on the next slide, why they looked at these mice specifically. But what we see is that with repeat exposure to morphine, the microbiome actually changes dramatically in the wild type, but not as much in the TLR2 and TLR4 knockout mice. To better understand what's going on here, in that diagram, there's that dotted line that comes down. That is net zero change. And so either side of that is log 2-fold change. So if you look, the red dots with the whiskers are the change in the morphine wild type, and you can see that those have migrated far away for the lactobacillus and the bifidobacteriaceae in the wild type mice when they're exposed to morphine, whether you look in the feces or you look in the gut itself. Now, interestingly, what they also decided to do was to use a commercial probiotic formula that was started before administration of opioids. And what they saw that there was significant blunting of this migration away from the change. So lactobacillus and bifidobacteriaceae levels were maintained close to normal when this probiotic supplementation was provided before administration of morphine. The reason why I talked about the TLR2 and TLR4, so it turns out that morphine actually exhibits activity, actually stimulates TLR2 and TLR4 in the gut, and that in turn induces IL-6, which causes inflammation, leaky gut syndrome, and all types of damage to the epithelial membrane. So what these same investigators did, if you look in the bottom there, is they expose TLR4 and TLR2 knockout mice to noxious stimuli, and what they saw is that there was significant in the animals that were knockout for TLR4. There was certainly better pain response, less tolerance, and then in the TLR2 animals there was a very, very good maintenance of response to morphine with exposure to painful stimulus. And then when they looked at IL-6 knockout mice, again, the same types of results were demonstrated. The next set of experiments done by another lab actually looked at the role of DHA and its effect on the microbiome. And I'm going to summarize this just for the sake of time, and I'm just going to represent this one slide. If you look at the letter B, the three little graphs that are there, those are representations of a microbial diversity. And what we see is the DHA-treated group, so DHA was given before initiation of oxycodone, and this is through the treatment with oxycodone. The microbial diversity is significantly higher in the DHA-treated group than in the control group. And then in the bottom D, if you look at the specific genus, it's hard to tell on this, but if you go into the details of the paper, what you see is DHA supplementation during oxycodone treatment actually significantly increased lactobacillus and bifidobacteriaceae colonies by 7 to 8-fold, and significantly reduced colonies of other potentially pathogenic bacteria. Now, this is important. The reason why, obviously we're focusing on lactobacillus and bifidobacteriaceae is because they're known to have beneficial effects and even anti-inflammatory effects in the gut, and obviously are important. So, in summary, one thing to discuss is that these are all animal studies, and human studies, at least for acute administration of opioid and development of tolerance, is incredibly limited. There is a lot of data on chronic administration and in addiction behavior, seeking behavior. However, that's beyond the scope of what I wanted to really go into today. But from these animal studies, what we can start looking at, and what future directions we really need to look at, is potentially the concomitant use of naloxone or methyl naltrexone. These are all medications that work specifically on the opioid receptors in the gut. Using probiotics, and then also potentially using DHA, initiating those before starting opioid therapy to maintain gut motility and to promote to modulate the microbiome so that the tolerance builds up at a much slower pace, so that people aren't looking for escalating doses of opioids to try to decrease their pain or to decrease their potential addiction. I put in the question mark here about the short-chain fatty acids because I know that Dr. Martindale loves this, and since he's one of the moderators, I wanted to make sure that I put that there for him. The issue with the short-chain fatty acids is they're not directly associated with opioid administration, but with opioids, if there is the potential for inflammation, short-chain fatty acids can significantly help to maintain that epithelial barrier and prevent gut translocation. Thank you.
Great. Great, Sadiq. That's very good and very interesting how we can relate this, how it all affects our motility and then obviously affects our microbiome. So the last one, then we'll have our questions. The last one today will be Caitlin Green, and she's assistant professor of medicine at MUSC, and she's going to talk today about, give us an update on where we are with fibers. There's been lots of controversy in the guidelines we wrote in 2016 about when we shouldn't. So she sort of gets us straight and sets us on the right path. Caitlin, go ahead.
Okay, thanks, Bob. I'm Caitlin Green, and as Bob said, I'm going to be discussing fiber in the ICU. Should it be a regular part of feeding?
Yes. Speak up, Caitlin. Speak up.
Okay. Can you hear me now?
Yeah.
Yes, much better.
So first, I'll review the classification of fiber, the known benefits in non-ICU patients. We'll review fiber fermentation, the current critical care guidelines. Sorry, I'm on the wrong slide. And the microbiota and critical illness. And then we'll look at fiber and various outcomes, including diarrhea, length of stay, infections, insulin and glucose, and safety. So clinically and in research, we tend to classify fiber by its solubility, which is determined analytically and is actually less predictive of fiber's physiological effects than, for instance, its fermentability or its degree of viscosity. Okay. So I think I'm having an issue with my slide order. Okay. Okay, it's just having a delayed click. So the benefits of fiber in healthy individuals and non-hospitalized patients is well established and goes beyond simply improving bowel regularity. I'm not sure if somebody else is pressing the slides. Okay, here we go, back to the slide. And so while this list is not exhaustive, it highlights, again, I'm not sure why the slides are moving. Okay, this is the right slide. It highlights the diverse and systemic benefits of fiber. Much of fiber's benefits can be attributed to its fermentation. Certain fibers, specifically those that are fermentable, can be broken down by commensal bacteria in the gut. And it's this fermentation process that yields the short-chain fatty acids, notably butyrate, propionate, acetate that that my colleagues have spoken about today, as well as gases into the gut lumen. And this has broad effects, as you can see, and probably impacts every organ system. These short-chain fatty acids are the preferred nutrition for colonocytes. They also lower the luminal pH, which suppresses pathogenic bacteria. They maintain mucosal health. They have a role in immune regulation, decreasing inflammation, decreasing tumorigenesis, and enhancing gut motility. And in supporting commensal bacteria, these bacteria then go on to produce vitamins, as well as digest residual plant cell wall that yields beneficial phytochemicals that have their own anti-inflammatory, antioxidant, and anti-neoplastic effects. The current guidelines on the use of fiber in the adult critically ill patient are somewhat conflicting. The most recent ASPEN and SCCM guidelines suggest against the routine use of a mixed fiber. However, they can be considered if there's persistent diarrhea. They go on to recommend a fermentable soluble fiber additive in stable ICU patients and recommend avoiding soluble and insoluble fibers in any high-risk patient. So a little history that helps us to better understand these guidelines. They came out after the ProPatria study, a randomized controlled trial in which patients with severe acute pancreatitis were given a probiotic versus placebo while on a mixed fiber EN. And as you can see here, the probiotic group on the upper line, the pink line, had more than twice the mortality as placebo. And while this study had a number of factors that may have contributed to the increased mortality, including that patients were fed into the duodenum, they were given high doses of fiber, this outcome likely influenced the guidelines, including the European and Canadian guidelines, such that ASPEN made no statement for or against fiber, while the Canadian guidelines cited insufficient data. Here we can see that in critical illness, there's a rapid and sustained decrease in short-chain fatty acids. In this study, stool samples were obtained from 140 critically ill patients with SIRS, and you can see that there were lower short-chain fatty acids compared to the healthy control, which is represented by the shaded line, and these levels remained low even 6 weeks out. This study establishes that fiber can in fact increase fermentation even in the critically ill patient on antibiotics. So here you can see that the first two columns show breath test evidence of recovery of fermentation following fiber supplementation in patients with severe acute pancreatitis. Diarrhea is extremely common in enteral nutrition and occurs in up to 72% of critically ill patients on EN. This is thought to be likely multifactorial due to changes in the microbiota inherent to critical illness, the use of vasoactive medications, gastric acid suppression, infections, and using enteral formulas that are devoid of fiber. And this has real consequences. So it can lead to interruption in tube feeds, inadequate nutrition, dehydration, electrolyte disturbances, skin breakdown with infections, increased nursing demands, and of course that leads to increased cost. So the data indicates that fiber is beneficial for diarrhea in the critically ill patient. In this randomized controlled trial of 120 ICU patients, we see that the 5-day diarrhea score is significantly lower in the mixed fiber group compared to fiber-free. as well as on day 5 of diarrhea, and there was even a trend on days 3 and 4. And then importantly, there were no significant differences between the groups with regard to other GI complications such as vomiting, regurgitation, or distension. In this study, septical surgical ICU patients on IV antibiotics were randomized to mixed fiber versus a fiber-free enteral nutrition for up to 14 days, and they also found significantly lower diarrhea scores in the fiber group compared to non-fiber group. 3 studies looking at length of stay also favor the use of fiber, despite having 3 very different patient populations. So in this first study, they looked at severe acute pancreatitis and found significantly shorter length of stay, 5 versus 10 days. In the ZAO study, it looked at post-gastrectomy, and then in the third study, it was looking at a septic surgical ICU population on antibiotics. Next, here we have data from a randomized controlled trial looking at a prebiotic fiber, which demonstrated that this can lower insulin requirements, probably due to insulin resistance, an improvement in insulin resistance, and this is despite there being a higher daily carbohydrate and total energy intake also in the prebiotic group. And again, this is important because it demonstrates that fiber can have a systemic metabolic effect. Here in a mouse model, we see that there's a change in microbiota as well as eroded colonic mucosal layer in the fiber-free group on the right compared to a fiber-enriched diet. And this leads to the question whether fiber can be protective for certain infections like C. difficile colitis. And in fact, in this in vitro study, this demonstrates nicely that increasing amounts of short-chain fatty acids and lower pH from fermentable fibers does in fact prevent C. diff toxin production. And indeed, there's also clinical data to support this as well. So in a study of hospitalized patients with C. difficile, those that were given a prebiotic for 30 days were less likely to have a relapse of diarrhea versus placebo at 8 versus 34%. The prebiotic group also had an increase in stool bifidobacteria, demonstrating this prebiotic effect. And then in another smaller study, acutely ill patients on antibiotics given a soy polysaccharide supplemented EN had a trend towards fewer C. difficile stool assays. This is an interesting study because it demonstrates that non-fermentable fibers can also positively alter the gut microbiota in a mouse model of sepsis. So here, mice were fed high, low, or normal fiber for 2 weeks and then subjected to sepsis by cecal ligation and puncture. And this graph on the right, you can see that the high fiber group had significantly higher survival after cecal ligation and puncture compared to both low and normal fiber fed mice. And then on the left, we can see that systemic markers of inflammation such as TNF were suppressed in the high fiber group compared to low and normal fiber. Next, they showed that the high fiber diet had a relative abundance of bacteria that are associated with metabolic health. This is the Akkermansia bacteria that Omar mentioned in his presentation as well. And then interestingly, the survival benefit of fiber is reversed after antibiotics, suggesting that the non-fermentable fiber offers a microbe-mediated survival benefit. This also highlights the need to be mindful of indiscriminate antibiotic use in our patients. So despite the benefits of fiber, there are safety considerations. One potential complication is gastrointestinal obstruction, but how common really is this? A review of the literature amounts to isolated case reports. So in this first case report, we have a patient who's septic with TTP on receiving motility suppressing medications as well as a pretty large dose of insoluble fiber. And this patient ultimately ended up having a cecal PSOR. In this case series below, from out of a burn center, intestinal obstruction was described in 4 out of 237 burn patients at an incidence of 1.7% over 3 years. And notably, these patients were reported to have suffered an episode of sepsis and hypotension, with 3 out of 4 of the patients requiring vasopressor support prior to the development of the obstruction. Okay, here we go. So non-occlusive mesenteric ischemia and bowel necrosis are rare but feared complications. There is a hypothetical concern that fiber fermentation could exacerbate this process. That said, there are very few cases in the literature. I came across 2 case reports of mesenteric ischemia in ICU patients given an insoluble fiber. And of course, GI intolerance manifesting with abdominal distension, bloating, flatulence, nausea, vomiting are a concern in both hospitalized and non-hospitalized patients, particularly with the initiation of fiber. That said, the evidence suggests that fiber can be well tolerated even in an ICU population. So in this first study, patients with necrotizing pancreatitis receiving up to 35 grams a day of soluble fiber had no increase in GI symptoms, and in fact there was resolution of diarrhea in a majority of the patients. Another study looking at severe acute pancreatitis described 3 out of 15 patients having gas and bloating that resolved after 48 hours. And then in the larger study, there was no difference in gastric residual volume, nausea, vomiting, distension, or regurgitation between the groups. And while seemingly trivial, clogged feeding tubes can be a nuisance, but they do have associated costs. They can also be inconvenient to the provider, as you can see here. But importantly, this can be mitigated with proper flushing. And in fact, a small study of septic patients receiving guar gum, there were no incidents of clogged feeding tubes. So in conclusion, fiber supplemented enteral nutrition, particularly soluble and mixed fiber, appear to be well tolerated and beneficial in hemodynamically stable ICU patients. They have the potential to improve diarrhea, reduce certain infections, attenuate acute inflammation, decrease length of stay, and decrease insulin requirements. By contrast, there are case reports that indicate that insoluble and mixed fiber may not be well tolerated in critically ill patients who are at high risk for GI dysmotility or those that are under-resuscitated. And finally, non-fermentable fiber also alters the gut microbiota in animal models, and more research is needed here.
Right.
Great.
Excellent.
Great. Caitlin, that was great. We can now open it up. But I have my first question. Maybe I'll take the first one. Each faculty member then can do one question, and we'll kind of read through. There's some 20-some questions been sent in to us, so we got lots of questions to answer. My first question for you, Caitlin, since you just finished, is, so now should we rewrite the guidelines and say we should use soluble and insoluble now in our ICU patients as a routine?
I would clarify. Yes, I would clarify to say that I suspect that there will be a revision of the next guidelines to include not just to include a mix of insoluble and soluble, given this favorable risk-benefit profile.
Okay, Steve, you want to go next with your question?
2 questions for Sadiq Karashi. You mentioned the effects of opioids on biodiversity, and is there any evidence that it changes virulence or brings out the pathogenicity of the bacteria? And then the second question is, everybody talks about antibiotic stewardship. Should we have opioid stewardship? This nobody should have pain has been a disaster. Can you comment on that? Both those questions.
Sure. Great questions. So the first one with regards to the pathogenicity, yes. So certainly it appears that predominantly through the changes in gut motility, what tends to happen is the more pathogenic bacteria start to ramp up their sort of relative abundance. And so the more virulent bacteria definitely start to increase in circulation. And then the double whammy to that is because opioids cause increased inflammation and basically leaky gut and degradation of the epithelial membrane, you get translocation of that, and that goes systemic and causes all sorts of problems. So that's certainly there. And I wholeheartedly agree with you with regards to the sort of opioid stewardship. We're sort of getting there, but it's hard to sort of to really for lack of a better word, police it, because as outpatients, we've tried to do that. But what happens is people then start turning to illicit or more powerful agents, and that's why you have this increase in opioid-associated mortality. In the hospital setting and ICU setting, that's something that I think that can be done a lot better, and different alternatives to analgesic therapy can be used other than opioids.
Yeah, and it's
how about Ryan? You got a question?
One more comment about that is that I would argue that we are already conducting opioid stewardship based on policies and protocols, and there's already been a dramatic reduction. And I don't think we call it opioid stewardship, but I think in effect
we're doing it.
Place.
Yeah, I agree with Laszlo. We're already doing it. We're as far as monitoring and restrictions and regulations and how much we can actually prescribe as far as total number of pills. I think we are actually, by regulation, like Laszlo said, actually having to restrict prescribing.
Ryan, do you have a question you want to ask?
No, I'm good right now.
Okay, Laszlo, you got one?
Yeah, I have a question for Vikram, if he's still on the line. And
Yep, I'm here, Laszlo.
One of my medical school colleagues was actually one of the authors on the Malawi papers. Mm-hmm. And you mentioned that was kind of the gold standard was the peanut-based nutrition formula. But then you went on to the trials demonstrating some of the local mixes. And I guess the question is, when we study these processes, should we really kind of focus on the sustainability and locally available formulas? Because in one sense, if you use a formula that's not available, it doesn't really matter what the outcome is if the local population can't get it in a sustainable fashion.
Yep, that's right. And I think that's what they actually did for the second study, the one that was based in Bangladesh. They looked at what was being done over there and some commonly available ingredients, things that people would not have found difficult to incorporate into their diet. And they made their formulations with chickpea flour, soy flour, peanut flour, and banana. And they thought that all of those were readily available, culturally appropriate. So I think they did a good job of that.
Yeah, it's kind of interesting because when you repeat this study, it really has to be done in the context of the local culture and their resources, because certainly there's been some experiences where the local staples are not providing enough protein. Or some of the rice-based cultures have that. And so a lot of times these studies need to be repeated locally.
I completely agree, Laz. I think what worked for this particular population in Bangladesh may not necessarily be applicable for other populations.
Okay. Keith, do you have any questions?
Sure. No, that was fantastic. Can you hear me?
Yep.
Yes.
Okay, fantastic presentations. I was just going through the moderator Q&A over here, and several people asked Rebecca a couple things. To re-clarify at what level they're looking at, specifically from the CT scan. I see 3 or 4 questions about that. And then, is there any literature out there to suggest that there may be incongruence with the psoas in certain patient populations, and it's not representative of their total muscle mass? I saw that question, which I thought was interesting, and I didn't know the answer to right off the top of my head. So those would be the questions for Rebecca.
And I'd like to add one more for Rebecca. How would we implement this program at our own hospital?
Oh, all great questions. So a lot of the data thus far look at patients mainly at the L3 level on abdominal CT scans, looking at the psoas muscle size at that cross-sectional level. There are other data out there, though, to support correlation along with other muscle groups, including the dorsal muscle groups. The advantage of the dorsal muscle groups is that you can use them to calculate a skeletal muscle index, looking or based on either chest CT or abdominal CT, because the problem is that the psoas muscle or L3 specifically, is not captured in chest CTs. So this allows us to have even a broader group of images to select from or apply to a broader group of patients. With regard to the question about, but again, there is the most data for looking at L3 specifically in terms of levels. With regard to your question about the psoas muscle not being predictive of sarcopenia in patients, I am unfamiliar with that literature, so I also cannot answer that question. And then your last question was about how to implement this. I think probably one thing that, or I think ways to potentially implement it, I think the group that would be easiest to implement this in would probably be our cancer patients who are receiving serial CT scans, because then you can measure sort of their progress over time, particularly if you're trying to institute nutritional therapies or prehabilitation or physical therapy prior to treatment, during treatment, after treatment, preoperatively, postoperatively, just because you're going to have all of the imaging data there. In the critically ill patient population, I think it would be helpful, and ideally over time, we'd be able to just have our radiologists say spit out a number associated with the CT scan once the technology gets advanced enough, so that as long as you're paying attention to that number, you can just look it up and use that to help you in your head classify the risk of the patients.
Yeah, that's the key issue you're getting at. Who should read the CT scan for sarcopenia? Should it be the purview of the nutrition team, or should it be radiologists and we can just ask that in the request for the CT? And will they pay for a CT scan if you're doing it for sarcopenia?
Yeah, I don't know that I'd necessarily do the CT scan for sarcopenia itself. I think
not worth the risk, Steve.
Okay.
You know, that was actually a question that came up in the comments, is that, who do you use this for? And someone pointed out that it's a really good point, is that if you already have the CT scan, like you mentioned, the oncology patients, but a whole other group of patients is trauma.
Right.
A lot of them get these trauma pan scans. And so if you're doing some planning or operative decision making, it's a nice tool that's used and really doesn't come at an additional cost. So it's a nice thing to look at, because a lot of the patients we take care of already have that data.
Right. And I will disclose I'm a surgeon, so a lot of my patients end up with imaging of some variety, whereas medical patients may have less scans performed. A lot of the patients I see end up having imaging of some sort.
Yeah, there is some growing data that we'll be able to use a chest CT and look at different muscle groups in the chest. And there's a little bit of data on the head and neck group that look at head and neck, and they're starting to look at whether it be sternocleidomastoid or other muscle groups and be able to use those. There's a little more speculation there, but we'll probably in the near future have various muscle groups. So if you only have a limited CT, you'll still be able to go with that. I have one more question for Sadiq. Sadiq, what about this DHA changing microbiome quantity and basically safety? What do you think the mechanism is? That was a question was asked.
Yeah, that's a very interesting question. So butyric acid specifically has some really interesting functions. Not only is it protective, not only is it anti-inflammatory at the level of the gut epithelium, but it also helps to reinforce the tight junctions between the epithelial cells. So it antagonizes the potential, sort of capillary leak that goes on when exposed to opioids. The other mechanism, though, that's really interesting is butyric acid does promote gastric motility as well. So it's a different mechanism. You know, the mechanisms related to opioids and gastric motility, yes, they're predominantly related to the opioid receptors within the muscular layers, but there are also neural connections that come from the cortical level that also modulate that. And butyric acid is one of the things that seems to sort of reverse that component of it. So if you really wanted to maintain good gut motility, rather than doing the things that we all try to do, use a prokinetic agent, your erythromycin and metoclopramide, maybe we should be doing butyric acid and a specific opioid antagonist.
Bob, quick question for Omer. Shaw, you talked about the amplitude of the microbiome changing with circadian rhythms, which means if we eat during the day, we're less likely to be obese than at night. What does the amplitude mean? Does the numbers of the bacteria changing, or their ability to extract calories, or their metabolites and function? What's changing with that exaggerated curve?
Yeah, it's the amplitude of both function, the metabolites, as well as the microbiome composition, the number. So when you are in time restrict feeding or this circadian rhythm, they call it oscillation, high microbial oscillation, as it relates to feeding and fasting during the daytime or the nighttime. So it's one is better off eating during the daytime when one is active in humans, or in particular in mice case, they are active at night. So when they are active, they are better off metabolically if they eat at night. So those who eat throughout the day and night tend to have low microbial oscillation functionally, as well as in composition-wise diversity, leading to bad metabolic outcomes.
When the functionality increases, they extract more calories. Is that the mechanism of the weight gain or weight loss?
No, no functionality like bitrate and protective metabolic products like bitrate will be higher when there is high oscillation, which has a protective effect.
There you go.
A couple of questions are related to this concept of feeding during pressors. We got several questions on the idea of, what about the stable patient on pressors? What about the cardiovascular ICU stable but on multiple pressors? Any comments on that, Caitlin?
Just that there's really no evidence. None of the studies included patients that were currently hemodynamically unstable on pressors. That said, the case series looking at trauma burn patients, those patients did, 3 out of the 4 patients did recently have hypotension and required pressors, and those patients did have a poor outcome. So there's really a paucity of data on that. And if you were to use fiber in the tube feeds, it would be prudent to monitor very closely for any signs of intolerance, as you should in any patient, any critically ill patient who's on your starting tube feeds.
And so then if you see distension or discomfort, increasing pain, then you'd back off on the fiber and just go to a standard formula, or back off on total feeding?
I would say you would have to back off on the feeding and the fiber.
Okay. Okay, it looks like we're already over about 4 minutes, and I'm being told we gotta cancel. I want to thank the 400 people who were participated and listened to us this morning. Thank you for all the participants. The presentation were very good, very diverse. Even though we had a theme towards microbiome changes, it was interesting. Probably fits with the theme in nutrition today. So thank you very much, and thanks to everybody, and we'll talk to you all later.